Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 16th episode of Optometry Series 2.0. I'm very happy to welcome my team members, Ms. Meenakshi. Hi, Meenakshi. Thank you so much for joining. And we're expecting Anshumam to join in some time. So I'd like to thank Anshumam also in this time. And I would like to welcome our today's moderator, Sridevi ma'am. Hi, Sridevi ma'am. Thank you so
Hi,
much for joining us as the moderator for the day, ma'am.
my pleasure.
Thank you. Thank you so much, ma'am. Dear audience, thank you all for your continued support towards Optometry series. The topic for today is choroidal diseases. In the last episode, we saw about the anatomy of choroid. So I'll be sharing the link in the description box. You can also view that video before this or after watching this video. Also, please go through that video. I'm very happy to welcome the MC for the day, Ms. Atifa here. Hi, Atifa. Please share us more details about the moderator.
Hello, ma'am. Hello, everyone. I'm Atifa from C18 batch, and I'm really glad to welcome you all to today's episode of our Optometry Series 2.0. It is my pleasure to introduce our session moderator for today, Ms. Sridevi. Ms. Sridevi is a senior optometrist with over 12 and a half years of clinical experience at Sankara Netralaya. During this time, she has mentored third year, fourth year, and fellowship students, shaping many young clinicians with her guidance and expertise. Ma'am has hands-on experience in computer vision clinic, binocular vision clinic, low vision clinic, and in the Department of Medical Biomedical Research, with a special focus on corneal and retinal cases. She has also worked closely in the retina clinic, where she has handled troubleshooting in special retinal cases with confidence and precision. Currently, Ms. Sridevi is living in the United States, taking a professional break while continuing to contribute to the field as a freelance optometrist. We are delighted to have her moderate today's session. Please join me in welcoming Ms. Sridevi. And to, speaker for today's episode is Ms. Harini, a third year optometry UG student. Over to you, Harini.
Thank you, Atifa. Okay. So today we are going to discuss on diseases of choroid.
Let me just a minute. Please put your screen in slideshow.
Okay, ma'am.
Yes, please continue.
Okay. Before seeing choroidal diseases, let me start with a quick review of choroidal anatomy. Okay. You all know that uvea is the middle vascular layer which presents between sclera and retina. The main functions of choroid is uvea is to supply blood and nutrition, regulating light and immune defense. Choroid is the posterior part of uveal tract which extends from optic disc to ora serrata. The inner surface of choroid is smooth and contracts RPE. Then the outer surface of choroid is rough and contracts sclera. The color of choroid is dark brown or black. The thickness is 0.22 mm posteriorly and 0.1 mm anteriorly. The layers the choroid includes three. The choroid is composed of three layers. First layer is suprachoroidal lamina, which is consists of collagen melanocytes and contains long or short posterior ciliary arteries and ciliary nerves. Stroma is the second layer of choroid, which is consists of loose connective tissues, hallux layer, Sattler's layer, and choriocapillaries. Third layer is Brooks membrane. It is located adjacent to RPE and helps in metabolic exchange of acts as a metabolic exchange barrier. It supplies blood through short and long posterior ciliary arteries and anterior ciliary arteries. The venous drainage is done by vortex veins and ophthalmic veins. Okay. These are the acquired diseases of choroid. Choroiditis can be caused by inflammatory, degenerative, vascular, neoplastic, and traumatic. Inflammatory choroiditis can be further divided into choroiditis, chorioretinitis, tuberculous choroiditis, and syphilitic choroiditis. Degenerative choroiditis is further divided into senile choroidal atrophy, myopic choroidal degeneration, and angioid streaks. Vascular choroiditis is divided into choroidal neovascular membrane and serous choroidopathy. Neoplastic is further classified as choroidal membrane, choroidal metastasis, choroidal hemangioma. Traumatic choroiditis divided as choroidal rupture, choroidal effusion, and choroidal hemorrhage. So, our first condition is choroiditis. It refers to the inflammation of choroid. Because the retina and artery are closely attached, choroidal inflammation almost always extends to involve the retina. This combined involvement is called chorioretinitis. It occurs at any age, but most common in young to middle-aged adults between 20 to 50 years. It's slightly female predominance in autoimmune-related forms. Infectious causes show no strong gender bias. High prevalence in regions with high TB burden. Toxoplasma chorioretinitis more common in South America and syphilitic choroiditis reported worldwide with increasing incidence due to rising syphilis cases. Infectious causes more common in developing countries. Non-infectious causes is more common in developed countries. The risk factors includes immunosuppression, systemic infection, autoimmune diseases, trauma or post-surgical inflammation. The most common etiology includes exogenous infection, secondary infection, and endogenous infection. Exogenous infection occurs after penetrating ocular injuries, following perforated corneal ulcer, and post-operative infection after intraocular surgery. Secondary infections are usually spread from nearby ocular tissues, including acute purulent conjunctivitis, keratitis, scleritis, retinitis, orbital cellulitis, and orbital thrombosis. Endogenous infections are caused by organisms that reaches the eye through bloodstream through the sources such as tuberculosis, syphilis, viral infection, fungal infection, toxoplasmosis, and septicemia. The clinical features includes defective or blurred vision, photopsia, photos, metamorphopsia, micropsia, macropsia, and positive scotoma. There are further clinical types including focal choroiditis, in which localized small patch of choroidal inflammation is seen. Then central choroiditis is an inflammation involving the macular and central posterior pole region. Then juxtafoveal or juxtapapillary choroiditis is an inflammation occurring adjacent to the fovea or optic disc. Anterior peripheral choroiditis is limited to the far peripheral fundus. Equatorial choroiditis is an inflammation that localized at the equatorial region of fundus. Multifocal choroiditis is multiple scattered inflammatory lesions in the choroid. Diffuse choroiditis are seen as widespread intensive choroidal inflammation involving large areas. These are the images of solitary idiopathic choroiditis and multifocal choroiditis. The complications and treatment. The complications of choroiditis includes anterior uveitis, complicated cataract, vitreous degeneration, macular edema, secondary periblephaitis retinae, and retinal detachment. This condition can be treated by prescribing periocular or systemic corticosteroids, immunosuppressive agents, and specific antimicrobial therapy depending on the cause, such as anti-TB treatment, IV penicillin, and antiviral or antifungals or antitoxoplasma agents as indicated. Chorioretinitis refers to the inflammation of both choroid and retina, commonly due to infections. It is usually caused by a HSV, TB, toxoplasmosis, CMV, and inflammatory reactions. Fundus appears as a creamy yellow retinitis with choroidal involvement and vitritis. The patient may experience decreased vision, floaters, and field defects. It can be treated by directed anti-infective therapy, systemic steroids, and mydriatics for comfort. It can cause complications such as recurrent retinitis, dense vitreous opacities, CNVM, and retinal detachment. These are the images of chorioretinitis. Okay. Our next condition is TB choroiditis. It is a choroidal inflammation which is caused by Mycobacterium tuberculosis. It is usually hematogenous spread from lungs hypersensitivity reaction to TB antigens choroidal granuloma formation. The fundus appears as choroidal tubercles, which is a small yellow nodules, and choroidal granuloma, which is a large yellow-gray lesions, serpiginous like lesions, minimal vitritis. The patient may experience blood vision, mild floaters, visual field defect, and systemic TB signs are experienced. The complications such as chorioretinal scars, CNVM, and permanent central vision loss can be occur. The next condition is syphilitic choroiditis, which is an ocular inflammation due to Trypanoma pallidum, affecting choroid and retina. It is a hematogenous spread of spirochetes, immune-mediated reaction seen in secondary or tertiary syphilis. The fundus appears as a placoid chorioretinitis, which is yellow placoid lesions at posterior pole, moth-eaten, RPE changes, variable vitritis, vasculitis possible. The patient experiences blurred vision, photophobia, floaters, metamorphopsia, mimics many posterior uveitis causes. It is also known as great imitator. It can cause various complications including persistent RPE changes, macular scars, optic neuritis, and recurrences if undertreated. Next condition is senile choroidal atrophy. It refers to a age-related degeneration of thinning of the choroid and RPE. It is usually caused by normal aging process, progressive thinning of choroidal stroma, and reduction in choriocapillaris density. The fundus appearance shows a pale fundus, prominent large choroidal vessels, and generalized RPE atrophy. The clinical features includes it is mostly asymptomatic and mild reduction in contrast sensitivity may appear. Various complications such as it may predispose to age-related macular degeneration. Our next condition is myopic choroidal degeneration, also known as pathologic myopia. It refers to the progressive degenerative changes in choroid and retina due to high myopia or axial elongation. It is usually caused by progressive axial elongation, choroidal thinning and RPE atrophy, and stretching of posterior pole structures. The fundus appearances shows posterior cephaloma, lacuous cracks, fugue spots, and pale papillary atrophy. The patient experiences gradual vision loss and metamorphopsia in advanced stages. It can cause various complications such as high risk of CNVM, progression to macular atrophy, and associated with myopic macular degeneration. These are the images of myopic macular degeneration. Our next condition is angoid streaks. It refers to breaks or cracks in Bruch's membrane. It's usually caused by calcification and brittleness of Bruch's membrane, often associated with seismic conditions. The fundus appears as a reddish brown or dark irregular lines radiating from optic disc and appears like a blood vessels but unrelated to vascular pattern. The patient, it is mostly asymptomatic in early cases, but can have reduced vision if macula involved. It can cause various complications such as pseudoxanthoma elasticum, Paget's disease, sickle cell disease, and high risk of CNVM. This is the image of angioid streaks. Okay. Senile choroidal atrophy can have no specific treatment, but observation is required to manage associated AMD if present. Nutritional supplements can be prescribed if indicated. Myopic choroidal degenerations can be treated by prescribing anti-VEGF injections. Low vision rehabilitation for advanced degeneration can be given. Myopic control lenses in younger patients and protective lifestyles like good lighting and reduced excessive near work can help as a treatment. Angoid streaks has no treatment for streaks themselves, but anti-AVG for CNVM and avoid trauma treat systemic diseases such as PSC, Paget sickle cells. Next condition is choroidal neovascular membrane. It refers to an abnormal growth of new choroidal blood vessels through defects in Brooks membrane into the sub-RPE or subretinal space. It is caused by breaks or weakness in Brooks membrane. It occurs as a secondary to AMD, pathologic myopia, angioid streaks, inflammatory choroiditis, or trauma. Fundus appears as a gray-green subretinal membrane. Subretinal or intraretinal fluid can be seen. Subretinal hemorrhage, pigment epithelial defect, or leakage on FA, hyperreflective membrane on OCT can be seen. The patient may experience a sudden drop in vision, metamorphopsia, and central scotoma. The complications such as subretinal fibrosis, deciform scar formation, permanent central vision loss if untreated, recurrence possible, and requires long-term OCT monitoring. CSCR. It refers to serous detachment of neurosensory retina due to leakage of fluid from the choroid through RPE dysfunction. It is usually caused by choroidal hyperpermeability and focal RPE leak triggered by stress or type A personality, corticosteroid use, pregnancy, sleep disturbance, or sympathetic overactivity. Fundus appears as a round or oval detachment of neurosensory retina with RPE mottling. Possible PED can be seen. Smokestack or ink blot leakage can be seen on FA. Subretinal fluid can be seen on OCT. The patient may experience blurred central vision, metamorphopsia, reduced contrast sensitivity, and hyperopic shift can be experienced. The complications such as chronic CSCR, which leads to RPE atrophy, then recurrences is common, may progress to CNVM, and long-standing cases cause permanent vision damage. These are the images of CSCR. Smokestack leaks. CSCR can be treated by observing. In most acute cases, it can be resolved by observation. We should stop corticosteroids and reduce stress. Laser photocoagulation for focal leaks can be used as a treatment option. Photodynamic therapy and mineralocorticoid antagonist can be prescribed. CNVM can be treated by anti-VEGF injections as a first-line treatment and then PDT in selected cases. Laser photocoagulation for extrafoveal CNVM. We should treat the underlying causes such as AMD, myopia, angioid streaks, and inflammation. Regular OCT monitoring helps in treatment. Our next condition is choroidal melanoma. It refers to a malignant tumor arising from choroidal melanocytes, the most common primary intraocular malignancy in adults. It's usually caused by proliferation of atypical melanocytes and genetic mutations of GNAQ, GNA11, and BAP1. Risk factors includes light skin, UV exposure, and ocular melanocytosis. Fundus appears as a dome-shaped due to subretinal fluid accumulation, and then orange lipofuscin deposits can be seen, and prominent intrinsic vasculature can be seen. The patient may experience blurred vision, photopsia, and floaters, and visual field defects. It has 4 stages. The first stage is quiescent stage. In it, a small peripheral tumors may be asymptomatic. The posterior tumors cause early vision loss. Second stage is leukomatous stage. It develops if quiescent stage is untreated. The secondary glaucoma due to obstruction of vortex veins leads to increase in venous pressure. Third stage is stage of extraocular extension. The progressive tumor growth penetrates sclera, often at limbus. The rapid fungation leads to orbital tissue involvement, leading to proptosis. A fourth stage is stage of distant metastasis. It is usually lymphogenous spread, but in rare cases, lymphatic spread can also cause distant metastasis. Liver is the most common site where metastasis happens. Metastasis is the main cause of death. Then choroidal hemangioma refers to a benign vascular tumor of choroid, either circumscribed or diffused. It's usually caused by congenital hematoma of choroidal vasculature. Diffuse type associated with Sturge-Weber syndrome. It causes choroidal vascular congestion. Fundus appears as a circumscribed round orange to red elevated mass. In diffused case, it appears as a widespread choroidal thickening, and the overlying subretinal fluid is seen. Bright hypofluorescence can be seen on FA. The patient may experience blurred vision, metamorphopsia, visual field loss due to serous retinal detachment, and often asymptomatic in early phase. The complications such as chronic serous retinal detachment, progressive visual decline, and rare malignant transformation can occur. These are the images of choroidal hemangioma. Our next condition is choroidal metastasis. It refers to a secondary malignant tumor deposits in the choroid from distant primary cancers. It is caused by hematogenous spread. The most common primary sites are breast carcinoma in females and lung carcinoma in males. Highly vascular choroid favors metastatic seeding. The fundus appears as a creamy yellow plateau-shaped lesion. Overlying subretinal fluids can be seen. Leopard spot in RP changes. Okay. The patient experiences rapid visual loss, metamorphopsia, and often associated with systemic cancer syndrome. The complications such as exudative retinal detachment can occur and indicates advanced systemic diseases. The poor visual and systemic prognosis can occur. The treatment of choroidal melanoma includes observation for small suspicious lesions, then plaque brachytherapy, then proton beam radiotherapy. Enucleation can be prescribed for large tumors or painful blind eye. The systemic evaluation and liver monitoring can be prescribed. In choroidal hemangioma, observation can help if asymptomatic. Photodynamic therapy helps as a treatment of choice. Laser photocoagulation and intravitreal anti-VEGF for associated SRF and radiotherapy can be prescribed for diffuse hemangioma, for example, Sturge-Weber syndrome. Choroidal metastasis can be treated primary systemic cancer using chemotherapy or hormonal therapy. External beam therapy includes standard ocular treatment, intravitreal anti-VEGF or steroids can be prescribed. Palliative care, depending on systemic status, should be given. Serpiginous geographical choroidopathy. It refers to a rare idiopathic bilateral recurrent inflammatory disease involving the choriocapillaries and RPE in a spreading geographic or serpentine pattern. The clinical features include cream-colored patches with hazy borders around optic disc. The lesion spreads in the tongue-like pattern. The healing leaves punched out RPE and choroidal atrophy. It has no effective treatment. Our next condition is birdshot retinochoroidopathy. It is a rare idiopathic bilateral chronic multifocal chorioretinitis strongly associated with HLA-A29. The patient, the clinical features includes numerous flat creamy yellow spots which appears as a birdshot scatter. Then focal chorioretinal hypopigmentation can be seen. It occurs in healthy middle-aged adults. There's no proven effective treatment. Our next condition is punctate inner choroidopathy. It refers to an idiopathic inflammatory choroidopathy affecting young myopic women, predominantly involving the macula. The clinical features include no anterior uveitis or vitritis, multiple small yellow to white macular lesions with fuzzy border is seen. Okay, mainly the treatment can be CNVM. Mainly CNVM if present. Steroid only in selected foveal involving inflammatory activity. Our next condition is relentless placoid chorioretinitis. It is a rare entity with features of both APMPE and serpiginous choroiditis, also known as amphigenous choroiditis. The clinical features includes numerous widespread placoid lesions and more aggressive and persistent than APMPE. There is no standard proven treatment for relentless placoid chorioretinitis. Our next condition is choroidal rupture, which refers to a break in the choroid Brooks membrane and RPE, usually following blunt ocular trauma. It's caused by sudden compression, the decompression of the globe. Shock wave forces cause tearing of Brooks membrane, choroid, and RPE. The fundus appears as a crescent-shaped or concentric streaks temporal to the optic disc. RPE disruption with yellow-white subretinal streak can be seen. It may have associated subretinal hemorrhage. The lesions are more visible after bleeding clears. The clinical features include sudden decline in vision, metamorphopsia, and central scotoma if macula affected. It can cause various complications such as CNVM formation, macular scar, and permanent vision loss if fovea involved. Observation can be the main treatment for acute hemorrhage. Anti-VEGF injection can be prescribed if CNVM develops. Monitoring of OCT and FA requires. Our next condition is choroidal detachment, which refers to separation of choroid from sclera due to accumulation of fluid or blood in the suprachoroidal space. It is caused by increased transudation or hemorrhage into suprachoroidal space. Why? Ocular hypotony, trauma and inflammation, uveal effusion syndrome, and hemorrhagic causes such as ruptured long ciliary arteries. Fundus appears as a smooth dome-shaped orange or brown elevation of the choroid. It is often bilateral and peripheral retinal vessels remain visible. A patient experiences blurred vision, pain, photophobia, and field effects. The investigation plans includes fundus examination, in which it shows direct visualization of choroidal lesion, hemorrhage, detachment, or tumors can be seen. FFA helps to evaluate retinal and choroidal circulation. It shows leakage, pooling, window defects, and CNVM activity. OCT helps to see the cross-sectional image of retina to assess choroidal thickness, CNVM, detachment, or edema. Hyperrectative findings in bright areas includes CNVM membrane for inflammatory deposits such as choroiditis, subretinal fibrin, hemorrhage close to retina, and tumor surface such as hemangioma or melanoma in edges. Hyporeflective findings in dark areas includes subretinal fluid, intraretinal cyst, serous or choroidal detachment, tumor shadowing, and areas of RPF. B-scan ultrasonography help to detecting choroidal tumors, hemorrhage, or detachment when media are opaque. Hyperechoic areas can be helped to diagnose calcification, tumor with internal reflectivity, hemorrhage, and fibrotic tissues. Hypoechoic areas helps in choroidal detachment, serous or exudative fluid, and low reflectivity tumors. Visual field testing such as perimetry helps to detect scotoma and peripheral field loss due to choroidal lesions. Laboratory tests helps to identify underlying infectious or inflammatory causes caused by VDRL for syphilis, Mantos for TB, Toxo IgG or IgM, ACE for sarcoid. PCR testing of aqueous or vitreous helps to detect microbial DNA in infectious choroiditis. CT or MRI can help in assess intraocular tumors, extent of invasion, or metastasis. OCT visualizes CNVM, choriocapillaries, flow voids, and ischemic patches and tumor microvasculature. To conclude, a multimodal combination of imaging and laboratory investigation enables precise detection, characterization, and monitoring of choroidal diseases, improving diagnostic accuracy and guiding effective evidence based on management. Thank you.
Thank you so much, Harini. It was so elaborative and based on acquired diseases, you have categorized almost all kinds of diseases under choroid, I guess. Now I request the moderator, ma'am, to add your valuable clinical inputs, ma'am. Here now.
Yep. It was a nice presentation. It would have been better if we have seen any one or two cases in addition with that, any choroidal cases. But it's a very detailed one. It's a good one. And I'll just include a few points whether when a patient comes with choroidal and it needs the surgical interventions and what an optometrist should do from our side, what we should do. So, what we need to note from the history till the treatments. So, I'll just cover those things. If a patient comes with CSCR, central serous choroidopathy, how we will find that he has that from the history, from our refraction? Anything we need to note from our side? Harini, any points you want to add in this?
Yeah, so the question is for you, Harini. Can you please answer?
Ma'am, I don't have any clue, ma'am.
So if the patient walks in with definitely they'll be having the blur vision, sudden blur vision in the case of CSCR. So from the history itself, we can ask them, did they have any recent stress and any steroid intake? And while doing vision check, definitely they'll be complaining. It may be unilateral. So definitely they'll be complaining of that blurred vision, central scotoma. When we do refraction, we do tend to have that hyperopic error. We'll get that hyperopic error. So why is it so? why that hyperopic error? It is not matching with their age. The other eye may be plano 6-6. The affected eye will give you a high hyperopic shift. Why so? Because of the
It,
accumulation of the
it may be due to edema, ma'am.
subretinal fluid. So that may be temporary when the stress is reduced, when the intake of steroids has been reduced, then that fluid will be reduced automatically. So that's why we don't prescribe the glass immediately after refraction or after the fundus evaluation immediately, even if the patient asks. So we'll just ask them to wait. So reducing the stress and that may reduce the SRF. That leads and the vision may come back. So you can give them the Amsler chart. We need to record that. And the other things, choroiditis. So it has the uveitis involvement in that. So while taking the systemic history, we need to be very careful whether they have any recent tuberculosis attack or any HLA B27 or B29. So all those things we need to record from the history, and by taking that itself, is it painful or painless? So we can come to a conclusion with that. So a detailed history helps us to connect with these diseases. We can assume, but without any diagnostic procedures, we cannot diagnose it directly with the history, but these history points will help us to lead to this. So whatever the test they have taken outside, the blood test, very important. Blood test and the tuberculosis, they must have done x-rays elsewhere. So those things will give us some idea uh, to help the consultant to go for the next test. And refraction part, it's very important. If the patient is young coming with the CSCR, it's not necessary to prescribe the glasses immediately. But if it is an old patient coming with that AMD and that CNVM, so if they have come with that and it is scarred, or it may or may not have the impact in the refraction. So we can push to the maximum, try the patient to give the uh, push them to read to the maximum, and we can try the higher ad, ask their lifestyle, whether they will read a lot, whether they have any near works. So a lot of near works, they need the reading glass. So we can push to the higher ads, even though we are not doing that full complete low vision clinic in the workup procedure, but we can try to give them the higher additions, and we can motivate them to read with eccentric viewing, eccentric fixation, make sure the other eye is blocked completely. So all those things we need to take care. And in CNVM, wet ARMD is there, in wet ARMD, CNVM, and anti-VEGFs when they give. So we need to note down how many doses they have given, because that anti-VEGF, what it will do, will stop the vascular endothelial growth factor, to stop that protein which releases those neovascularization. So that happens. So that anti-VEGF intravitreal injection which they are giving, it will be only to a particular period. Then again they have to repeat the injections. So multiple injections need to be given, and in that injection also we have to be very careful, because few injections are steroids, like injection Osidex. It is a steroid. When it is given, we have to note the IOP as well. So it leads to that also. So IOP should be very accurate. We need to check that if it is beyond the normal, then gonioscopy should be done. So all those things we need to take care. And neovascularization of iris also we need to note down. And that multiple injections, everything we have to make a note. And yes, and when we say that choroiditis, most of the cases are autoimmune. So maximum treatment will be through the steroids. It may be systemic steroid or oral steroids, oral or topical steroids. So they will include, you have said, the cases in birdshot chorioretinopathy, um, placoid chorioretinitis, serpiginous geographical chorioretinopathy, choroidopathy, all these things, they will combine the treatment with the corticosteroids and immunosuppressives. So there is no not typical, there is no treatment at all. It's not like that. They will try with the steroids. And the CNVM, it's a main part in the macular degeneration. It's like that creature coming in the Stranger Things. However, how many injections we are giving, it keep on coming. So we need to push the patient, and we need to every visit we have to see by doing repeating the OCT. We need to compare with the previous visit whether it is scarred or the CNVM has increased or not. So it helps the consultant to decide on the injection. So apart from that, other things are fine. So only the bread and butter is refraction from our side and noting a proper history. So refraction, try as much as possible. And if the patient has high astigmatism, prescribe them a separate reading glass in spite of giving them the bifocal glasses. So give them a separate reading glass and try to do the proper history. Includes the systemic lupus erythematosus, so Behçet's disease, Sturge-Weber syndrome. Patient comes with that, and that gives the combination of glaucoma and uveitis. So we need to be more careful with these kind of systemic. We should not move these systemic diseases apart, because when it comes to choroiditis, it is very important to note all these things. And whether they have taken any TTT treatment, PDT. So all those things we need to note it down.
Okay, ma'am.
Yep, I'm done.
Thank you so much, ma'am. It was so nice having the theoretical part and the correlation with the clinical inputs. Anshi, ma'am, do we have any questions for our moderator, ma'am?
Hi, Sridevi. Hi, Meenakshi and Gomati. I do not have any questions as such, but yes, I would just like to summarize. As you said, we were having a very good correlation between choroidal diseases and the clinical correlation. So, for an optometry student, why should choroidal diseases matter? So, first thing we have to remember that choroid is the eye's blood supply hub. So, it nourishes the outer retina, including the photoreceptors. So, any problem in the choroid can directly affect the vision. And as already Sridevi mentioned, that many eye-threatening diseases start there. For example, be it CSR or be it CNVM or it be ARMD. We are the first ones to notice the changes because majority of the diagnostics are done by optometrists. So could it be fundus examination or it could be FFA or it could be OCT. So optoms are generally the first one to detect them. So timely referral is very, very crucial in understanding any choroidal disease because we can actually save the patient from any life-threatening diseases. So that's my take-home message. And thanks, Sridevi, for pitching in and being such a good moderator. Thank you, Harini, for a very nice presentation. Over to you, Gomati.
Yes. Thank you so much, Sanchika ma'am. And Sridevi ma'am, thank you once again from the team of Optometry series and Dr.
My
Agarwal's
pleasure.
Institute of Optometry. Thank you so much, ma'am. We'd like to host you on another wonderful platform in the future, ma'am.
Yeah, hoping to.
Dear audience, thank you all for your continued support towards Optometry series. Meenakshi and Anshika ma'am, thank you so much once again for all the support. And Harini, that's a great presentation. Best wishes for your future. Audience, if you have any questions, you can put your questions in the comment box. We'll get back to you with the answers. If you like this video, give a thumbs up and share with all your friends. The announcement for this particular week is that we are almost completing all the exams at Dr. Agarwal's Institute of Optometry. So new season, new semester starts next month. All the best to all of our students, UG and PG. And the admissions are open for Pan India internship at Dr. Agarwal's Institute of Optometry and fellowship also. Anshika ma'am, would you like to add points on fellowship admission, ma'am?
So we do have 6 months clinical fellowship available, 1 year clinical fellowship available. We are starting with the new cornea fellowship, which is cornea and refractive fellowship for 1 year. And we also have a pediatric fellowship available for 6 months. So students who are watching our YouTube series also, so do enroll for any kind of fellowships you look for.
Yes. Thank you so much, Anshika ma'am. Thank you all for your continued support. We'll meet in next episode. Thank you. Bye. Bye. Thank you, Sridevi ma'am.